This is Dr. Robert Watkins, orthopedic spine surgeon to professional athletes and creator of the Back Doctor app.
Hi, so today's topic is failed back surgery. If someone's had back surgery and they're still having pain, what are the potential causes and can anything be done about it? It's one of the biggest issues that people on my Facebook channel ask me about. They've had multiple surgeries, they're still having pain and are asking for help. And in general, it's one of the big things we deal with. And one of the big knocks on back surgery you've heard is that people know someone who's had 2 or 3 surgeries and still is in a lot of pain, and what can be done about it. So it's a difficult topic, but I'm going to try and give you some ideas to our thinking and our approach of how we make judgments and decisions as to why did the surgery fail and can something be done about it. So first of all, the big question is, if anybody's ever had surgery, is did they have the right surgery? What was the preoperative diagnosis? What was the source of the pain before the surgery? Was the right surgery done to address that pain? And was the surgery done properly? And then what do things look like now, and can it be fixed? And this is not a black and white answer. That's one of the hardest things that people don't really understand about spine surgery. It's not like a hip or a knee. I tell those doctors they got it easy. You got an arthritic hip, you replace the hip, it's the end of the story. Spines are much more complicated. Look at all these moving parts, discs and facet joints and nerves. It's much more complicated. So we never know for sure what exactly is causing somebody's pain. Well, that's one of the reasons why the surgery may not work, is because maybe we didn't know what was causing the pain correctly before we did the surgery. And part of it is we're dependent on people to tell us where their pain's coming from and to describe it, because we can't measure the pain. So as far as going back to that preoperative diagnosis, we look back and we say, okay, what pain did you have before the surgery? Did the surgery treat some of your pain, but not all of it? And part of that is, what are your expectations? Do you have unrealistic expectations? Were you at an 8 out of 10 pain before the surgery, and now are you at a 3 out of 10? Well, that's a successful surgery, and maybe we can't get you better. But if you're still at a 7 or 8 out of 10 after surgery, well, then something may be wrong, and something may be fixable with another surgery. So part of it is there's different types of surgeries, right? There's decompressive surgeries. If there's pressure on a nerve from stenosis or a disc herniation, and the surgery is decompressive, it takes the pressure off the nerve, well, like with a microscope and without any metal or no implants. So then the question is, well, did the surgery successfully take the pressure off the nerve? And the best test is get an MRI. So we get an MRI with contrast, typically to show us scar tissue versus disc. And we see, is there still pressure on the nerve or not? Well, if there's still pressure on the nerve and it matches the distribution of the nerve and we think that's causing the pain, we may be able to do another surgery, another decompressive surgery, where we go in and make a little more room for the nerve, and maybe that'll help. That's an easy answer. That one we got. Another thing is, after you've had a decompressive surgery, is maybe everything looks okay, but there's some scarring around the nerve. Maybe the nerve is stuck to the back of the disc, and when you move, the nerve still gets irritated, and that's why you're still having pain, even though the MRI looks pretty good and things are pretty open. Well, that's a tough situation, because the surgery for that could potentially be a fusion. And a fusion stops the motion across the disc and the facet joints. So if the nerve is scarred to the back of the disc and tethered and hurts whenever it moves, fusing it by stopping the motion may treat the scarred nerve that's still irritated and inflamed. But that's a little second step. We don't know for sure if that will help or not. But if somebody's symptoms are bad enough and they're not getting better with non-operative care, it may be worth fusing a nerve that has some scar tissue around it. And then that other category is a fusion. What if somebody's had a fusion? You've already got screws and rods. Here are the example of pedicle screws. Here are the screws and rods in the back. And maybe they're still having pain. Well, what is the potential source of the pain? So again, we go back to, well, why was the surgery done in the first place? Do we think that was the right surgery to do? And then the question is, well, is it fused? A fusion was attempted. Well, did the bones actually fuse? That's the first question. And it's kind of crazy to do a fusion, because we're trying to stop the motion across a moving part. Your body wants this disc and joints to move, and we're trying to stop the motion and get the two vertebrae to fuse together, to literally grow together across this mobile disc space. That's really biomechanically demanding and challenging. And I know patients sometimes get really upset if they had an attempted fusion and it didn't fuse, and they feel like the doctor failed and didn't do a good job. And that may be true, but usually in my experience, that's not really the case. The case is we were trying to overcome natural biology and weren't able to. And it's kind of more a miracle that it usually is able to happen than sometimes when it doesn't happen, because it's just biomechanically demanding. We put in these pedicle screws and rods and grafts and biologics to get it to fuse, and with modern techniques, our successful fusion rate of getting bone to grow can be greater than 95%, which is pretty remarkable. But guess what? That's 5% or less, even 1% to 2%, that sometimes it still doesn't fuse. So the first thing we do is get a CT scan to see, is there bone growth across the fused segment? Did the fusion successfully work? Reasons why it may not work is not enough stability, not enough biology. Maybe somebody has poor bone quality, maybe they smoke. Different reasons can cause it. But basically, did it fuse or not? Now, if it did not fuse, well, that's a reason for pain, because the micro motion that's still occurring across this segment can cause pain. It's inflamed. It can really hurt a lot. So one of the options is, if it's not fused, get it to fuse. Maybe do another surgery with more hardware, more stability, going from the front, going from the side, put in big spacers and really get the stability and better biology to get it to fuse. So, and then another option after fusion, say it is fused, where the CT scan shows bridging bone and flexion extension x-rays show no motion. And we also get a bone scan, which is that great test I explained on one of my previous videos and podcasts, that basically shows metabolic activity of osteoblast bone-making cells and stress in the disc and in the joints. And we'll get a bone scan. If the bone scan lights up hot at the fused level, it means it's probably not fused. Now, it can be delayed. It can still stay hot for up to a year or two after the surgery. But if it's been 4 years and it's still hot, it may not be fused, because it's still, your body's still trying to heal it. What if one of the levels lights up above or below the fusion, an adjacent level? Well, that can be the source of the pain, because we fused one level, stopped the motion. That can put more biomechanical stress on the discs above and below. They may start to accelerate their degeneration, be a source of pain. The pain may be coming from that. So after a fusion, we want to check, is it fused? Then we want to check the other levels. Are they a source of pain? And then obviously we want to check the SI joints, the hips, organs, anything else that may be causing the pain that maybe hasn't been accounted for yet. And then one of the other options is, sometimes people still have persistent pain that we can't do anything about. And that's where I really like to try and educate people to understand, did you go from an 8 to a 3? Well, if you're still at a 3 and you're not happy because you can't play basketball or even work or do, other activities, maybe that's as good as it gets. Maybe you still have residual pain that we can't fix with surgery. And that's just one of the brutal realities of my job and of spine patients, is we can't always get rid of it all. And that's where we look at more alternative techniques, like the David Schechter techniques, that my last interview I did with him, where you can do more mind-body connection, relaxation techniques. That's where physical therapy comes in big. Get your core strong, get the muscle strong to keep the stress off the spine, to decrease some of the pain. And that's where we look at these other alternative techniques. Then the other issue about fusion I wanted to bring up is, sometimes if you've had the decompressive surgery and the nerve is irritated, we also look for, do you have any instability? We check the flexion extension x-rays if you have a spondylolisthesis or some instability, or if the nerve is being pinched out in this foramen, out in this hole out on the side. The decompressive surgeries don't treat that real well. They really treat the central canal better. And if the nerve is being irritated out in the foramen, then sometimes doing the fusion can help treat that pain that may still be residual after a surgery. So in summary, basically, our systematic approach is, okay, what surgery was done? What were their symptoms before the surgery? Do we think the right surgery was done? And maybe sometimes we try and do a less invasive surgery the first time, and maybe it just doesn't work. And we tried it, it didn't work, now we may need to do the fusion to treat it. So one thing we look at is, what was the preoperative symptoms? Was the right surgery done? Did it work or not? Then we get an MRI to see, is there any nerve compression? If they had a fusion, we'll get a CT scan, see is it fused, get a bone scan and the other x-rays, see if an adjacent level is causing the source of the pain. And then it comes down to, is it worth doing another surgery? Well, if your pain's an 8 out of 10 and we can identify the source of the pathology, it may be worth having another surgery. If you've had 3 levels fused and everything looks fused and everything else looks okay, and you're still having a 5 or 6 out of 10 pain, it may not be worth having another surgery, because another surgery may not get you better. And so that decision-making process is one of the interesting parts of my job, because we're like a detective and it takes a lot of time and to spend with people, and it can really help. And I hope that this information has been helpful to you. If we can help, please reach out. I'll put a post in the comment section about some of the things we can offer for how to help non-operatively potential surgery. And hope you guys have a good day, and I hope that's helpful. Thank you.